business is very well organized, and I want to continue to respect the rule. So I'm very proud as a past president of ISOP, but now currently the president of SciAMS, to introduce the SciAMS lecture. The SciAMS lecture has been decided under the auspices of my predecessor, Professor Alex Dodou. I'm not sure he's here. But we decided in 2010 to create the first SciAMS lecture. The goal of this lecture was to inform you on what are the main topics and the main working group of interest of the SciAMS. And this time, we decided to talk about the drug-induced liver injury, which will be released, and the guideline will be released very soon. So we will give you some insight, and it will be presented. We will have a forehand presentation with my close colleagues, Alexandre Olry. So I will just make you a very brief introduction of what is SciAMS. In theory, everybody of you should know what is SciAMS, but I heard somewhere that what is SciAMS, so I will try to do my best to explain, because SciAMS is an old lady. So what is SciAMS? It is a Council for International Organization for Medical Sciences, and it is a 60-year-old lady. It has been founded in 1949 by the WHO and the UNESCO. We are in official relation with WHO and observer of ICH since 2016. So the main statement and the mission of SciAMS is to advance public health through guidance on health research, including ethics, medical products development, and safety. So, very briefly, the SciAMS, the organization is located in Geneva. It's international, it's non-governmental, and it's not for profit. We are, of course, today in official relation with WHO and an associate partner of UNESCO. And for WHO, health authorities, academic organizations, pharmaceuticals industry, and other concerned stakeholders, it is an organization of medical science organization. So, for you, what is it? It is a forum of discussion and a neutral platform to elaborate new ideas in medical products development, pharmacovigilance, and research in ethics. And in a way, it is complementary to the mission of ISOP. And I would be very happy to continue the collaboration initiated so close to 10 years ago, as soon as ISOP will continue to be a learned society and an independent society. I insist on this. So the mandate is to publicate detailed report guides and guidelines with common results on working group stakeholders. It is a platform for debate with the existing emerging issues in medicines and health policy. It is a forum for biomedical stakeholders, and it is linked to, of course, the United Nations with WHO and UNESCO. So as you can see, we have a lot of members. You can't be an individual member. You can be members for an organization. So it's not like ISOP. You can be individual. You can be nominated. Sorry? I'm told finally. Okay. So I'm a great president. Usually it's like this in radio. Okay. So I let you see the different member. So you can be member as a representative of an organization, and we have many organizations. It would be too long to describe all of them. But you can be also asked to participate to the working group as an expert, if you have a special expertise. So how is organized the SciAMS? You have the executive committee. I'm the president of the executive committee. We have a vice president, and I would like to pay a tribute to my secretary general, but a lot of you know him. It is Professor Lembi Trago, who had a very important role in WHO before, and who is now the secretary general of the SciAMS, and I can tell you how much it is important in this organization to have an excellent Secretary General. And once again, I would like just to thank him for the excellent work he do. We have a secretariat and we have a member organization at the level of General Assembly, and of course we have a collaboration with partners from authorities, international organizations dealing with related topics like WHO, PAHO, HEMRO, ICH, and others. So what are the main working groups? We had a lot of working groups, but it began with the SIOMS form of reporting of the side effect. It was the SIOMS 1. So at least people know what is the SIOMS 1. But you can see that we work on international reporting of periodic safety, update summaries, guidelines for preparing core clinical safety information on drugs, benefit-risk balance for marketed drugs in 1988. And we now created a new group to renew this new concept. And finally, I let you see, because I want to leave the floor to my colleagues, but the last guidelines published were on SIOMS Guide to Active Vaccine Surveillance and SIOMS Guide to Vaccine Safety Communication. Of course, what is important is that we have a close interaction and we have not on opposition with ICH, but we try to collaborate because there is room for everybody. And I will give you some example of the impact of the SIOMS guidelines on the ICH guidelines. And so you have the SIOMS working group on, of course, the ICH 2E1 clinical safety data management. You have the SIAMS 1A report reported in ICH E2B. You have SIOMS, Working Group 5 report on post-approval safety management, definition standard, and so on and so forth. So you see that we are not at all, like some people could say, we are not at all in opposition with ICH, but we are definitely in collaboration. And I will be in 1 month, no, less than 1 month, in 2 weeks, in Singapore for the meeting, the International Assembly of ICH, representing the SIOMS. So just to remind you what is case report form. I just would like to come back on the working group because they are the core of the SIOMS. So the SIOMS working group are international, first of all. The SIOMS working group involves the regulators, the academia, the industry, the WHO as member observer of the group, and others. And they involve also representatives of interested in topic SIOMS member organization. And in some working groups, representatives from organizations such as ICH can also participate. So we try to be extremely balanced and to have all the opinion, because the goal is to have a consensus to be applicable in all the big legislation, all the big agencies. So the current active international working group concerns the MEDRA implementation working group. You will have some insight about the working group on drug-induced liver injury. We have currently a working group on clinical research in resources-limited setting, and a group on patient involvement in development and safe use of medicine. And ISOP, as mentioned Sten Olson yesterday, ISOP is member of this group. So, what is the rest? We have a new revised SIOMS ethical guidelines, which has been translated in many, many languages. And we have topics for new potential working groups on medical device safety, severe cutaneous adverse reactions specific for certain groups, big data, artificial intelligence, and utilization on real-world data. But I hope that next year I will be able to give you more information about this. So, as a conclusion for the first part, and before leaving the floor to my colleagues, since inception in 1949, SIOMS has served public health well in its priority area of works, meaning ethics and medicine safety. A lot of progress has been made in developing effective systems for expediting patients' access to safe medicine, However, as we often say with Lembitrago, working for Publicis has a problem, is that no matter how good you are, you can also do better. So thank you very much for your attention. I will give the floor for the jury. Thank you.
Hello, everybody. So the topic of my lecture today is a daily working group created by the SIAMs. So, So the aim of this working group was to coordinate several initiatives from regulators, academics, industry partnerships, and patients in order to avoid redundancies, to improve dissemination, and to widen the audience about the daily concerns. So, as I said, the aim was to establish a balanced and efficient global perspective on daily detection, susceptibility factors, severity, outcome, and probability through causality assessment tools, monitoring and management during the drug development and post-marketing phases. So, why the DD is a growing challenge? Because the DD is responsible for more than 10% of all acute liver failure, and its crude annual incidence is around 20 cases per 100,000 persons, according to the study of Ennard Bjornsson. Moreover, among all of drug and traditional medicines available today, several hundred have been associated with the DD. In addition to those safety issues, the DD is a problem for the regulatory agencies because it's mainly recognized and identified in post-marketing phases, and it's the most frequent reason for marketing drug withdrawal and modification of labeling. So let's talk about the DD definition, because the DD definition is an evolving concept, because at the beginning, the DD was defined as an increase of the ALT transaminase upper than twice the ULN, then 3 times the ULN by the SIAMs. But now, with the increased incidence of conditions like non-alcoholic steatohepatitis, this threshold was raised to 5 times the ULN. So now, the DD definition is an international consensus, and it can be defined as an increase of the ALT upper than 5 times the ULN, or an increase of the alkaline phosphatases upper than twice the ULN, of course, in absence of any bone pathology, or it can be defined as an increase of the ALT upper than 3 times the ULN, associated with a total bilirubin level increase twice the ULN. In addition to this DD definition, there is a classification which divides the DD in 3 subcategories, and we can cite the hepatocellular injury, the cholestatic injury, and the mixed injury. The hepatocellular injury, meaning that the main target is the hepatocytes. For the cholestatic injury, the main target is a bile duct, and for the mixed injury, there is a balanced targets, sorry. So this classification is not truly scientifically based, but it's still interesting in terms of prognosis for the clinician, because, by example, an hepatocellular injury, even if it's not truly linked with a specific mechanism, is more at risk to evolve in an acute liver failure or in a fulminant hepatitis. As another example, a cholestatic injury is more at risk to evolve in a vanishing bile duct syndrome. So, with the DD, there is different mechanism, and I will focus on the 3 main mechanisms. The first one is a direct mechanism. It's the most well-known. And for this mechanism, there are important characteristics, but the direct mechanism is predictable. Its frequency is common, and this mechanism is dose-related. And as a typical example, we can cite the acetaminophen. On the contrary of the direct mechanism, there is the indirect mechanism, which is partially predictable due to an indirect action on the liver or on the immune system. And as a typical culprit drug, we can cite the rituximab. But after all, the main mechanism is idiosyncratic, because this mechanism is a major issue, because it's unpredictable. The animal models are not reliable, and this mechanism is responsible for the most frequent drug withdrawal. And that's why the science group was created in part. So, this slide displays the most frequent causes of idiosyncratic prescription. Excuse me. The most frequent idiosyncratic drugs. So in this slide, you can see the antibiotics are the most representative, but this slide is not really comprehensive because the because the increase of the DD detection will improve this table. So now let's go more in depth about the main issues with the idiosyncratic drug-induced liver injury. The main issues are about the diagnosis, the causality assessment, the predictive models, the prevention, and the monitoring. Concerning the diagnosis of the drug-induced liver injury is a challenge because currently there is no test from imaging, histology, biology, or any other biomarker that is enough sensitive and specific for the diagnosis. So, the DD diagnosis remains an exclusion diagnosis and relies on a comprehensive clinical assessment. Of course, the liver biopsy remains the gold standard, but as you can imagine, it's not routinely used. About the causality assessment now. Despite some attempts from creating liver-specific causality assessment scales, there is no method considered as a gold standard for the DD. However, the use of an expert's opinion to identify the DD could constitute a serious alternative. Now, just some word about the predictive models, because currently we lack of the predictive models to identify the risk of DD during the non-clinical trials. During the clinical testing, aside the usual hepatic testing, ALT, SAT, ALP, and total bilirubin level, there is no specific approved biomarker to predict the DD concerns. However, AV research are currently conducted to develop new biomarkers to identify the DD. Now, about the prevention. The recent progress in research on DD have been determined by key development in 3 areas. The first is the emergence of new technology, which now allowing the identification of the genetic risk factors with improved sensitivity, specificity, and efficiency. On the other hand, a better understanding of the hepatotoxicity mechanism of DD emphasizes the importance of unspecific downstream events following drug-specific initial upstream hepatocyte injury and of complex interaction between environmental and genetic risk factors. And there is the development of the new biomarkers which allow to qualify and upgrade the DD detection, diagnosis, and outcome. Now, about the monitoring. There is no clear monitoring processes for regulatory agencies as soon as the idiosyncratic DD is diagnosed. Now, what can we expect from the Science DD Working Group? And there is some deliverables. There is the identification of the DD signals in clinical trials and during the post-marketing monitoring. There is the harmonization of clinical DD assessment, the analysis of existing re-challenge data, the risk minimization strategies, the DD in spatial population studies, the standardization of the case report form for prospective multicentric data collection, the DD risk management and communication, the causality assessment methods for DD, and the assessment of the drug DD potential and the benefit-risk balance. So, to sum up, the DD Working Group is a strong and unique collaboration between several international actors as regulators, academics, industry, patients, in order to propose an harmonization on the DD assessment and recommendation, on the DD communication, on the DD drug causality assessment, and on the DD risk minimization strategies. Their guideline will be published soon and will constitute useful tools for the DD detection and diagnosis. Thank you for your attention, and if you have any questions.
Thank you very much. So we have time for some burning question or non-burning question. Yes? Can you introduce you and yeah?
Hello, Hervé. Here, Pedro Lima from Sanofi. We have nowadays I know that the setting is completely different, but for renal failure, we have some algorithms from artificial intelligence that can predict, and physicians may not like that. I'm one, I can understand, they may be very bored, but they are very precise, high sensitivity, specificity. Is there anything being planned for daily, like building algorithms with computer and intelligence, artificial intelligence?
Tu veux répondre? No, good question, but the kidney is not the liver. And for the time being, we have some track, but it is under embargo until it will be released in 1 month and a half. Now, I think that what is very important is what the point 5 of the last presentation is that I was member of the PRAC, and as soon as we detected some delay, how to monitoring this. With the kidney, you can always try to deal with good biomarkers, with not the biopsy, but it's more easy to understand. I don't say that the physiology is better, because it's very complicated, but for the liver, it's a very wide area. And so for the time being, we have some tools which are not yet validated. And so we have some track, but it will be released because for the time being, I will not betray my colleagues from EMA, FDA, and the other one. I think there was a question here.
Well, I don't have a question this time, I just have a comment. I think that these lectures from Science Working Group are definitely the highlights of the ISOP meetings, and I do hope that Professor Louet will find time in his busy schedule to keep providing us updates from the CM's Working Group in the future ISOP meetings. Thank you.
Thank you very much. And happy to collaborate with you because I know that you're a specialist of the drug-induced liver injury too.
This is Priya. I would like to follow up Katarina's remark about, because Science has access to, obviously your members are like the real healthcare professional organizations. Is there more possibility for ISOP also to reach out and make our messages from pharmacovigilance?
As soon as you have an expertise, you can join us. Of course, you're a member of Science, but we try to gather the best in a specific area, so we can put everybody in every group.
I mean, when we as pharmacovigilance community, can we sort of make our messages from pharmacovigilance more heard through the Science as a...
But Priya, I think that my presence here is a thing.
I know that. I'm saying if there could be more. Basically, I just want to acknowledge that and say we should do more. Thank you.
No, but of course, it's more open.
Hello, I'm Jose from Mexico, and I understand that there is a really difficult situation about how to diagnose the DILI. So how have you, or what have you done to make this more easily for the clinician to be able to diagnostic and not to think in other before diagnostic? Like, how have you done, or what have you implemented so they can observe it and understand that this is related directly to the drug, to the medicine?
If I understand well, your question is that how can we define with very old biomarkers how to diagnose everywhere in the world? It is an issue. And of course, it is mainly for the time being dominated by the North America, by the Europe, by people who have the same problem of liver, due most of the time to obesity. And of course, we must take into account all the other countries. But I can't for the moment, there is some epidemiologic study who will show that finally it's not so easy like that. And for the time being, we have no other option than the old biomarker. But I agree with you, to define a DILI with only ALT or ALP is very poor. But we have a lot, really a lot of biomarkers, but we lack of epidemiology on this type of biomarker. And in my opinion, the next step will be really to implement new tools, but it's on the way. But once again, I can't reveal everything today.
Okay, thank you very much. With regard to the drug industry liver toxicity, drug industry liver toxicity or liver injury, we have many challenges in the national centers or regulatory authorities because it's very challenging when you come to risk minimization plan, especially if it is idiosyncratic or maybe monitoring strategies. So in your guideline, please consider the low-income countries. I mean the practicality in low-income countries, because in these countries there are no laboratory setups are really inadequate in the lower health facilities, but the drug might be very important to be used at a lower level. And also the time to onset of the DILI. Time to onset is very important because, for example, some might encounter after a month or 2 months, so you have really an opportunity for monitoring strategies, but others might manifest as early as 10 days, as early as maybe a week. So in this case, I would like to see something on the monitoring and risk minimization plans in this case.
No, but I fully agree, and you are not the only one. But there is two questions in your question. The first one is, what are the main criteria to finally, when you have a DILI, according to the severity of the DILI, the seriousness of the DILI, do we have to monitoring every 2 weeks or every month or other thing, which with biomarkers, and after you have to adapt to the place where you are. For example, in some country of Europe or North America, you can do at least everything. You can test every biomarker. If you are in other country of the world, you can't. So there will be 2 phases to identify and to validate the new biomarkers and to give, to prioritize finally which kind of biomarker are the most important and what can be done according to the public health in each area of the world. But once again, it has never been done before. So it is a first step. And of course, we will continue with this group, with other satellite group. We just want to have a first release. But after, we will have to deal also with traditional medicines, which are not the issue with the DILI. So it's just the first step. Okay, so another question.
Excuse me. Sorry, me again. Actually, you just said traditional medicines. In Mexico, we have a big issue with those traditional medicines and hepatotoxicity. So, like in one of our hospitals, Instituto Nacional de Ciencias Médicas y Nutrición, that it's one of the most prestigious investigation hospitals in Mexico, there is a group of just focused on researching that kind of dangerous relationship between traditional medicines and the incorrect use of them, and the hepatotoxicity, the DILI. So I think probably the next step should be exactly that, traditional medicines, and to go to the countries that are more with those kind of issues. At least in Mexico we have a really big issue. We have many people that are entering hospitals and dying for this kind of
But it is
situations.
a very important information, because when I began to study the traditional medicines, I was only thinking that mainly was concerned China, North Africa, and some. But finally, you realize that it's everywhere, even in Europe, and the most important frequency is in the US with nutraceuticals. So it is really a worldwide issue, and we try for the time being to work with the IUFAR, which is another network of experts, to create a big group. And to come back to what you said, Pedro, is that finally it is also a problem of kidney. So the problem at the beginning, we say we will do a traditional medicine-induced liver injury, but I think we will do a traditional medicine-induced injury, including the kidney, the liver, and probably the blood, which are the main area of interest. Okay, so if there is no other question, I will leave the floor to the next speaker. Thank you very much.